Today's webinar on resilience approach towards rare disease policy in India. We all know that we are fighting out a bad pandemic, COVID-19, and it's all about numbers. And we've been tracking how many people got infected, how many people met with an outcome, how many cases are active. But let us bring our attention to an entity, a group of conditions where we do not know the exact numbers, the rare disease space. So about 7,000 to 8,000 entities have been identified, documented across the world as rare diseases. And it is estimated that about 300 to 400 million people worldwide are afflicted with it. But we still lack a very robust case definition for tracking these conditions. The numbers are also just guesswork. Coming to the etiology, we know that about 80% of these conditions are of genetic origin. For the remaining 20%, we do not know what the cause really is. In a country like India, which has the largest birth cohort globally, it is quite logical to infer that we have a huge burden of people with rare diseases. Now, these people face a gamut of challenges. It's very difficult because these conditions are quite unique. It's very difficult for the family to identify where and how to seek care. Even the healthcare workers see these cases very occasionally, maybe once in an entire career. So it's very difficult for them to make a diagnosis, to guide proper management, and even provide good counseling and referral services. Industry struggles because these are not sustainable business models to provide drugs and interventions for these rare entities. And the state government, because of lack of evidence, fails to design effective policy, which is not just effective in reaching out to the people, but is also quite efficient in resource utilization. The government of India did attempt to come up with a draft policy, National Policy for Treatment of Rare Diseases 2017. But that had to be put in abeyance because there was a need to have wider stakeholder consultation and also a more comprehensive synthesis of evidence, learning from best practices worldwide. The policy was open for feedback to the public, and the government is currently re-looking at that draft policy. Now, the fact that we have all come together today shows our commitment to enhance the resilience of rare diseases, which now run the dual risk of having a policy deadlock as well as being sidelined due to the pandemic. Before, we have a very knowledgeable panel of experts who represent various constituencies. We have representation from patient advocacy organizations. We have academia and research. We have industry. We have state government. And we also have representatives from family of people with a rare disease. Before we listen to them, let me please request Dr. Lakshmikant Palo, the Chief Executive Officer of People to People Health Foundation, to give a warm welcome to the panelists and the participants, and also provide a high-level brief of the rare disease space in India. Over to Dr. Palo.
Thank you, Dr. Mahapatra, and good morning, everyone, and welcome to today's webinar. I would like to thank you all for your participation in this important webinar on rare disease. We are pleased to host this in collaboration with Takeda and Grid Council. The initiative aims to bring key stakeholders together to work collectively and collaboratively to prioritize the need of people suffering with rare diseases. This is our second event in the series. The first one that we organized in the month of February, when the draft national policy for rare disease was open for comments and recommendations. We organized a roundtable discussion in the month of February with FICCI and other stakeholders, and a collective recommendations were shared with the Ministry of Health, the Prime Minister's Office, and the other related ministries to include those recommendations into the final policy, national policy on rare disease. We hope that the policy will be open very soon so that we can see those recommendations will have been kind of reflected, and we'll be able to have a clear policy going forward. The agenda for today's webinar is resilience approach towards rare disease policy is the priority setting for rare disease in the health agenda. So the rare disease, as you know, that is a unique public health challenge to us, such as lack of access to diagnosis, quality care, and effective medication. Those are and there are many more other challenges. The numbers are very small, but rare disease conditions are often very complex with high burden of disease and suffering. COVID-19 pandemic grips nation's attention, but people with rare disease suffer silently. We need to recognize people living with rare disease as high priority, high risk population and provide them adequate support. I think this webinar is one of those initiative to set the context in the background of in the arena of COVID-19. Today we have combination of very high level speakers from USA, academia, industry, ministry, and patient advocates in India to help us better understand the opportunities and challenges for prioritization and management of rare disease. I would express my sincere gratitude to our speakers. People to People Health Foundation is committed to building greater collaboration with the key stakeholders working on rare disease, aiming to achieve greater visibility for rare disease in public health agenda. Also, I express my heartfelt thanks to Dr. Mahapatra for moderating today's session. Dr. Mahapatra is the Executive Director of GRID Council. He is a public health expert and having decades of experience in public health programming and research. And Dr. Mahapatra has been a part of esteemed organizations like INCLAN, ILBS, Save the Children, Nizam's Institute of Medical Science. He has been awarded several research and academic assignments by several renowned international universities. I am looking forward to your active participation and insightful discussion today. Our special thanks to Takeda for supporting this series of events, and I would welcome you once again for this webinar. Thank you, and over to Dr. Mahapatra.
Thank you, Dr. Palo, for that warm welcome and kind introduction. Now, let's get started with the day's proceedings. Rare diseases require very strong advocacy efforts, and it's multi-dimensional strategies that really work. Now, in this particular area, the National Organization for Rare Disorders comes up as one of the most prominent patient advocacy organizations. We have a recorded message coming from Ms. Rachel Sher, who is the Vice President of Policy and Regulatory Affairs at NORD, National Organization for Rare Disorders. Ms. Rachel leads NORD's strategy for engaging with federal and state legislatures and regulatory agencies to effect positive change for the rare disease community. She has nearly 20 years of experience in health policy, having served in the Commissioner's Office at the Food and Drug Administration and worked at the Capitol Hill for about 10 years on many federal healthcare issues impacting rare diseases. She has apologized for not being present in person, but her recorded message is with us. So I'd request that message to be played, please.
Hi, my name is Rachel Sher, and I'm Vice President for Policy and Regulatory Affairs here at NORD, the National Organization for Rare Disorders. We are a group that was founded in 1983, and we represent over 320 rare disease patient organizations, as well as the over 30 million Americans who are struggling with a rare disease. We are committed to the identification, treatment, and cure of rare disorders through programs of education, advocacy, research, and patient services. I want to thank you for inviting us to speak with you today and apologize that we can't be there in person or even virtually live at the time. I'm glad you're having this conference and am happy to share with you the policy work that NORD is doing both in and outside of the context of the COVID pandemic. I want to be clear first that the policy issues that we're going to be discussing here today are ones that are relevant to the United States and may or may not be relevant for you there in India. Happy to share these remarks, and if you would like more information following your conference or after today, please feel free to be in touch with us through our website, rarediseases.org. Let me start with just an overview of a lot of the policy work that we do. In the policy department here at NORD, we like to think of trying to get at policies that really address all of the needs that the rare disease community has. We work today and have worked for many years on issues surrounding affordable and adequate health insurance coverage. That takes many different forms here in the United States. Many of the members of our community receive care through federal programs like Medicaid and Medicare. Many of them also have insurance on the private market. And on all of these counts, NORD has a long history of advocating for the Affordable Care Act, which is now law, although there are efforts to undermine it. NORD has been very active in trying to thwart those efforts and ensure that the Affordable Care Act and the expanded coverage that it provides continues. So that's one front. Obviously, for the rare disease community, another really critical part is access to effective and affordable and safe therapeutics and medicines. NORD was founded in 1983 and at that time actually helped to get the Orphan Drug Act enacted. This is a law that provides for various forms of incentives in the rare disease space to industry so that they remain interested in developing therapies for what are small patient populations. NORD has a very long history, as I mentioned, of working to protect this act, and it remains just as relevant today to make sure that those incentives remain in place. As I'm sure you know, there are over 7,000 rare diseases, and in the United States, over 90% of those rare diseases do not have an FDA, the Food and Drug Administration, approved therapy. So that's something that we are constantly working to try to make sure is a problem that is reversed. We work very closely with the FDA and really want to make sure that they have the resources and the regulatory science at their disposal that they need to address the need for getting these therapeutics on the market. Similarly, making sure that industry has appropriate incentives and resources to continue to invest in this really critical area. Another area that I know that people are interested in worldwide is ensuring that there is funding for research to be conducted on the underlying science of rare diseases. In the United States, the National Institute for Health is one of the leading scientific thought leaders, and we work closely with them as well, wanting to make sure that they have the resources they need to continue to provide grants to academic medicine facilities and others to ensure that the research that underlies rare disease work in the United States continues. So that is another area. We also work extensively on access to diagnostics. That is everything from whole exome screening and newborn screening, which is a big issue here in the United States too. NORD has a long history of working in these areas. Let me turn now to the impact of the COVID pandemic on the rare disease community. And I know you had a particular interest on the ways in which the COVID pandemic have impacted the utilization and uptake of telemedicine in the United States. Indeed, if there is a quote bright side to this pandemic, I would say that is what it is. So many people in the rare disease community have for many years tried to get access to broadened telemedicine. And in the midst of this pandemic, we were seeing uptake like we've never seen before. In the United States, prior to this, it was quite low. And some of that was due to physician resistance to change. But a lot of it also had to do with legislative and regulatory barriers that made it difficult, if not impossible, for patients to be seen remotely by their healthcare provider. All of this really changed in the COVID-19 pandemic. Suddenly, there was a real need to reduce possible exposure to COVID-19. And part of that meant keeping patients out of hospitals and doctor's office unless there was an absolute emergency. The USA's Centers for Medicare and Medicaid Services, which is akin to an agency within your Ministry of Health and Family Welfare, decided to use emergency authorities granted to them to rapidly expand the types of patients and providers eligible to utilize and be reimbursed for telehealth services, including allowing patients to be seen in their home using either audio only or video technology. Medicare, which is the United States healthcare coverage program, typically available to those ages 65 and older, averaged about 13,000 patients utilizing telehealth services a week prior to COVID-19. During just the last week in April, about 1.7 million patients used telehealth. This expansion in telehealth services is really critical to the rare disease community. Many rare disease patients have been at higher risk for becoming seriously ill from COVID-19 if they leave their homes for routine medical appointments and were to be exposed. Rare disease patients often, as I'm sure you know, have to travel significant distances, often hundreds of kilometers, to gain care for their routine healthcare providers. And that's just a risk they simply can't take in the midst of the current pandemic, given the immunocompromised nature of so many of their conditions. NORD recently did a survey of the rare disease community to help to understand the impact of COVID-19. With regard to telemedicine, our survey found that out of over 800 respondents, more than 83% had been offered a telehealth visit during the COVID-19 pandemic by their healthcare provider. And of those that were offered that visit, almost 88% accepted. 92% of patients who reported having had a telehealth visit described it as a positive experience. This is really encouraging news for a patient population that depends on being able to access quality healthcare services in order to thrive. But one thing we at NORD are thinking about as we think about how to carry forward the lessons related to telemedicine that we are learning in the midst of the pandemic is that we need to make sure we have a balance. We know that telemedicine is not appropriate for all patients or for all conditions. NORD believes that patients and their healthcare providers should be able to make a choice on the location and type of care they receive that's based on what's in the best interest of the patient. Patient choice has got to be what is preserved and guides our path forward on telemedicine. Patients shouldn't be pushed to or away from telehealth by their health insurance plans or healthcare providers. While many rare disease patients have expressed relief and satisfaction at their ability to use telehealth services during the COVID-19 pandemic, NORD thinks that it's incumbent on Congress and the administration to put patient choice at the center of the debate about which aspects of telehealth to make permanent beyond the COVID-19 pandemic. We are going to be continuing to work to lead and support policies that enable telehealth to be an option for patients if and when they and their providers decide that it's in their best interest. Again, thank you for having us here today, even if it's virtually. I want to reiterate that we are happy to answer any further questions and look forward to continued dialogue with all of you in the future. Thank you so much.
So that was Ms. Rachel Sher from NORD, USA, with a recorded message. During her message, she talked about multiple aspects which would require advocacy efforts at the policy level. She touched upon insurance, affordable care, ensuring outreach, and she also talked about therapeutics and diagnosis, role of industries, what concerns industry might be having, the need to mobilize more funds for research, to undertake research. And she also spoke about the optimism that comes with the pandemic with regard to uptake of telemedicine as an alternative way of accessing healthcare. So the participants can check NORD websites, and if they have any query, they can direct them to us so that we get them resolved from Ms. Rachel. I have two notifications for the participants. First, we are live on Facebook, on the PPHF Facebook page as well, so you can access us from there as well. And the second one is that if you have any questions, please just scroll down to the bottom of the screen. You'll find an icon popping up, Q&A. Type your message here, and we are keeping a track of all of that. So we'll try and get them addressed from the panelists that we have for the day. We will be having 2 poll questions after each speaker, and you'll be getting about 30 to 45 seconds to answer those. And all you need is to answer yes or no, or maybe choose the third option. Is this the poll button? Yeah. So choose your button. We have some time. First one, can telemedicine be a sustainable dynamic when it comes to rare diseases post-COVID-19 pandemic? Make sure that you click on one of the options. Right, coming to the next question. To improve patient access and enrollment in clinical research during the pandemic, which strategy is best suited? A decentralization model for clinical trials, virtual approaches, or a mix of both? Once you have made your choices, press on the submit button and we'll display the results once the poll closes. Perfect, we can close the poll and display the results. Yes, so 72% of you have suggested that telemedicine is a sustainable dynamic for rare diseases. Of course, there are certain positive aspects, and learning from US experience, there is an opportunity, but in Indian context, there are also challenges related to technology adaptation at both ends, from the provider end, from the care seekers end. The good news is that we have had revised guidelines coming from the Board of Governors, MCI, in collaboration with Niti Aayog, and that gives some hope, but those are guidelines. Legal frameworks are still awaited. Coming to the trials, it is very difficult to run trials because it's very difficult to get adequate sample size. So a mixed model seems to be more logical, more practicable. Now moving on to the next speaker, we have Professor Madhulika Kabra, and she is from the Division of Genetics, Department of Pediatrics, All India Institute of Medical Sciences, New Delhi. So the Division of Genetics at AIIMS New Delhi is a WHO collaborating center, and it is also a center of excellence for training in genetics as per the Government of India. Dr. Kabra is a very decorated researcher, and she has received multiple lifetime achievement awards in recognition of her great work, especially in the rare disease domain. She is a member in various technical and policy-making committees for rare diseases. Dr. Kabra would speak about the Indian scenario for rare diseases. So she'll walk us through all that is available and all the knowledge that we have regarding rare diseases in India. Over to you, Dr. Kabra.
Good morning, everybody. Thank you very much, Dr. Mahapatra, for a very, very kind introduction. I'm really thankful to PPHF for involving me in this webinar on a subject which is really close to my heart. Can I have my first slide, please? So I'll be speaking on the rare disease scenario in India. We all know that rare diseases are a global challenge affecting about 6 to 8% of the world population. About 7,000 rare diseases are known as of now, but treatment is available for less than 5% of these. And as you already heard, about 80% of the etiology is genetic. So whenever we are talking of this challenge of rare diseases, it has to be a combined effort from all fronts. And we also need to keep in mind when the policies are made, we need to keep this in mind that patient needs are similar in all countries. Next slide. So for today's presentation, I just noted down few situation analysis points, particularly for India, which I thought are important from the rare disease and rare disease perspective, primarily which are genetic in origin. So I'll be talking about epidemiology, the education status, the patient care status, public awareness, prevention programs, and status of research. I'll not be talking about the rare disease policy because it is under review and it is in the public domain as of now. And I'm sure the government will be coming out with a very, very good rare disease policy soon. Next slide. Next slide. Okay, so first coming to the epidemiology. So the definition of rare disease, we do not have any universal definition for rare diseases. Different countries would use different definitions. India as of now has no standard definition, primarily because we do not have prevalence data available. So there is an urgent need for community-based data for prevalence of rare diseases, though we are generating some data from the newborn screening programs which have taken place in the country for the last few years. Next slide. Next slide. So almost a month before the previous rare disease policy was released, we had a meeting called National Initiative for Rare Diseases, and it was a collaborative meeting with the ICMR, AIIMS, and the JNU, and all the stakeholders were at one platform to discuss the issues related to rare diseases in India. But the most important thing here was that there was a launch of the rare disease registry, which was to be funded by the ICMR. Next slide. Now this funding is already been initiated. Multiple institutions all over the country are involved, and this is the workflow of the registry which you can see here. So common demographic data, specific data for specific group of disorders. One nodal center will take care of a group of specific disorders. AIIMS is the coordinating center. All participating centers submitting data directly to the ICMR, confidentiality would be maintained, and a very efficient team at the ICMR, data coordination and data analysis center. Next slide. So this is the group of disorders, 6 groups of disorders which have been involved initially in the first phase of the registry. And you can see here that most of these are the ones which have some kind of treatment available, like lysosomal storage disorders, small molecule diseases, immune deficiencies, etc. Next slide. But next slide, please. We have to keep this in mind that this exercise will not generate prevalence data because this will be hospital-based data, but definitely we will get numbers of patients who are coming to the hospital and will definitely help in planning management for these patients. Next slide. So coming to the next important issue of education and awareness regarding genetic disorders in the medical professionals. So here also in the last few years, there have been tremendous progress. We have multiple DM courses available in the country now. The only one initially started long back was at SGPGI Lucknow, but now many centers have that, and these are comprehensive state-of-art programs for a comprehensive training of the doctors. But we need many more programs in the country because we have huge number of such patients which are to be taken care of. Next slide. Apart from these 3-year exhaustive courses, we have some short-term courses also available, like fellowships, especially to mention the DBT Ummeed fellowship, which is for clinicians both in the lab and in the clinical genetics area. We have ICMR courses, we have society fellowships, and we also have genetic counseling courses. So bottom line here is that there has been an evident improvement in the knowledge, awareness, and interest in the area of rare disease and genetic disorders in the country in the last 1 decade. Next slide. Next slide. Coming to the genetic services, again, a very, very important component. And a good news here again is that as of now, we have almost all investigations available within the country, and we need not send investigations outside the country, both in public and private sector, but public sector needs more strengthening. We have some free programs also running for the diagnosis by CSIR. In all domains of diagnosis, molecular, cytogenetics, and biochemical, we have basic investigations and also state-of-art like NGS investigations also available. Cost is still high, so we need to teach people for the judicious use. And a very, very important thing here is the early diagnosis. So early suspicion and diagnosis goes a long way in managing these patients. Another important thing is we have to have emphasis on centers with comprehensive facilities which are lacking. And very, very important issue when we are talking of genetic diagnostics is the issue of quality assurance and other ethical regulations which have to be kept in mind always. Next slide. Now coming to the treatment status, as I already said, a very small proportion of cases of rare disorders have specific therapy. So we have to rely on supportive therapy, and supportive care needs strengthening all over the country. Cost is the major issue for specific therapies, as most drugs are not manufactured in India. Many patients are on treatment under CSR and humanitarian initiatives. One-time treatment help is available under Rashtriya Arogya Nidhi. We have reimbursement also going on. Guidelines for treatment, which are extremely important when we are talking of rare disorders, is there and it has been formulated. There has been relaxation in the DCGI rules for drug trials and experimental therapies. But here we really need to take into account that how do we take care of the cost which is involved in taking care of these patients, and this will, I hope, come in the policy which will be declared soon. Next slide. Now, these are just the numbers which I could collate of the patients who are getting enzyme replacement therapy and other therapies like for spinal muscular atrophy under reimbursement and under humanitarian initiatives. These numbers may be more also or a little less. These are just a collation which I got. But the important thing here is that these numbers may be much less than the actual numbers of the patients which are there. And here the sustainability of the treatment is the key, because for many disorders, it is a long-term or even lifelong treatment which is required. Next slide. So I was talking of the treatment guidelines, and these were formulated in a consultation meeting in July 2018 with the support of Ministry of Health and Family Welfare. This was an extension of the initial recommendations which were made by Dr. V.K. Paul committee, and the expert groups met, and these disorders were divided into 3 groups. One for the one-time care, which is supported by RAN. Then you have long-term treatment, but the cost is relatively less. And then you have long-term treatment and many challenges because proper patient selection is important and very high cost is involved. That's the third group. So we tried to make some inclusion, exclusion, and exit criteria for the available treatment at that point in time, and we tried to be as objective, transparent, and unambiguous as possible. These are with the ministry now, and these will have to need some revision because it is 2 years since we formulated these policies. Next slide, please. Next slide. And this is what I was referring to, the amendment in the new drugs and clinical trial rules, which has been recently released and is in the public domain. A very, very important step which has been taken by the Government of India and the DCGI. And we really need to go further in the area of the Orphan Drug Act, which will go in a long way for development of drugs for the rare diseases in India as well. Next slide. Now coming to in my mind, the most important component of rare diseases is the prevention at all levels, primary, secondary, and tertiary. We have to strengthen the secondary level of prevention by prenatal screening, prenatal diagnosis, genetic counseling, and newborn screening also, which is a type of secondary prevention. And obviously at the tertiary level, I have already said supportive facilities for improving the quality of life. So strengthening at all levels is required. Next slide. Next slide. So about newborn screening. So over the last many years, India has really done well in the area of newborn screening, and many projects have been funded by many funding agencies. and even state governments have started running their programs. So bottom line here is that it is feasible in India and the expertise is available. And the second thing is about the birth defects registry, which is being run by the WHO, has collated a large amount of data which gives us prevalence data for the birth defects. Some of them could be very rare. And now the Rashtriya Bal Swasthya Karyakram is also planning to have a similar program. Next slide. Next slide. Now we all have to integrate these services at the community level whenever we are planning to give services to everybody. So this is another initiative by Department of Biotechnology, where various institutions have been assigned or they have adopted aspirational districts. We have adopted Haridwar district, and here we are working on the antenatal screening of mothers who are at high risk for genetic disorders, and also providing newborn screening. Next slide. And this is a comprehensive program of the Rashtriya Bal Swasthya Karyakram, which I was mentioning. So this would include structural birth defects, the heel prick newborn screening, hearing screening, congenital heart defect screening, and also high-risk screening in the babies who are admitted in NICUs and SNCUs to pick up metabolic disorders. And this will give us some prevalence data as well. Next slide. And these are some evidences to show that there is increasing evidence amongst the public. There are multiple patient support groups and the numbers are increasing. They are celebrating rare disease days. Next slide. Next slide. And these are multiple organizations which are there in the country who are extremely important for improving patient care in the area of rare diseases. Next slide. So finally, what has happened in research? Good funding for research has been done and we are doing well. I have mentioned the rare disease registry. The 4 points in blue which I have mentioned are specifically targeted projects or task forces for rare disease management and the research in the area of rare diseases. This has actually bridged the gap between scientists and clinicians, which is extremely important. Publications are there in large numbers, novel genes have been identified, but we need to focus on drug development research, and also probably a consortium for rare disease research is required in India to take the research forward. Next slide. So whatever I have said so far about the epidemiology, the patient care, the awareness, research, and so on and so forth, this can be collated in such a way that we start from the community and go to the tertiary care and the regional centers and divide the activities at different levels. And at each level, we have different activities going on. And the regional centers and the tertiary care referral centers focus more on research, but there has to be a very good referral and networking system to ensure universal access. Next slide. Next slide. So to conclude, we are in a new era of rare diseases, which is very exciting. I have discussed about a steady progress in the area of diagnosis and research. Drug development needs strengthening. We have to find best possible modalities for therapies, how they are to be funded. Financial issues and sustainability issues are there, but I'm sure though we have a long way to go, but we are going to do it. We can do it. I cannot end my talk without mentioning about these two stalwarts in the area of medical genetics, Professor I.C. Verma, who laid the foundation of medical genetics diagnosis, counseling, and research, and Professor S.S. Agarwal for laying the foundation of medical genetics education in the country. Next slide. So I end my presentation here by saying thank you very much for giving me a patient hearing, and let us join hands to care for the rare. Thank you very much, and these are my acknowledgements for the patients and families, humanitarian access programs, expert groups, various funding agencies, patient support groups, and my own team, genetics, which is shown here. Thank you very much. Because of this team only, we have been able to do some work in the area of rare diseases. Thank you very much.
Thank you, Professor Kabra. That was a very informative and comprehensive presentation. I can immediately realize that while we are struggling to get good data, you have been able to collate all of that together. And you touched upon various aspects, right from awareness to availability of care, to affordability, and to access. And it was very heartening to see that rare disease efforts have seen a programmatic translation as well. So some embedment into RBSK, Rashtriya Bal Swasthya Karyakram. You also talked about the need for comprehensive diagnostic and treatment facilities. You emphasized on quality and ethics. You also suggested various capacity building efforts that are ongoing, and the need for having further data integration in terms of a registry and ensuring early diagnosis so that more and more could be done for these individuals with rare diseases. I have one question for you before we go into the goals. So we have this COVID-19 pandemic and it is unprecedented. We really didn't know how to react to this, and we have been doing whatever we could. How do you see this would have affected the care of individuals with rare diseases? And what kind of interventions or efforts do you see are more likely or should be undertaken?
Yes. So, I mean, as for all other patients, for rare disease patients, maybe there is something more special about it because there are few centers all over the country. So during this pandemic, it is very difficult for them to access the facilities even for initial diagnosis and follow-up. And the patients who were on treatment, many of them were coming to distant places for their, say, for their infusions and other treatment. So that got interrupted, and because local facilities were not there. And then also many of them are prone, because of immune deficiency disorders and things like that, are more prone and can be very severely affected with COVID infections also. So that prevention is also required. So these were multiple things which were happening, and everybody in the group was facing this. So I think the way out here is that, one, as you already said, teleconsults and video consults, and this is being done by the whole group which sees the patients with rare diseases, and patients are quite satisfied. We heard Rachel talking about this also. And the other thing which was done and is continuing to be done is that we contacted the local doctors there who were there and tried to sort of tell them that how they can take care of these patients, and even home treatment somehow was we tried to do that also. And it is heartening that many local doctors agreed to help these patients and successfully administered treatment to them. So I think with as time goes on, I think we should probably strengthen the local health practitioners to take care once we have made the diagnosis and we have guidelines for management of these patients.
So that's really promising to see quaternary centers connecting directly to the community level providers. And clearly there is some effort going on, and we shall be doing even better in coming times. So thank you,
Sure.
Thank you, Professor Kabra.
Thank you
For the
very much.
presentation. We'll take a quick poll. 2 questions coming up for the participants. How can patients' access to proper treatment be improved without compromising the quality of treatment in the most feasible manner? So you have to choose whether it has to be a dedicated state level treatment center in each state, or digital clinics at the centers of excellence, or regional branches of center of excellence. So choose one of these 3 options. Right. So we go to the next one. Should an earmark budget with contributions from public-private sector for prevention and research on rare diseases be part of the policy in India? Right. So let's close the poll. I hope everyone has participated. Okay. So it seems that people want a mixed model. So they want dedicated state level treatment centers in each state, as well as regional branches of centers of excellence. That sounds like a good idea. And of course, overwhelming support to have a budget earmarked for public and private sector, with public and private sector contributions for research and prevention activities. So thank you everyone for participating in this poll. Let us move on to the next speaker. So we know that health is a state subject in India. So it's basically up to the state to take up very affirmative, very strong actions to salvage the situation of rare diseases. And it is the state efforts that will show up as overall impact on the Indian epidemiology. We have Dr. Sanjeeva GN, who is an associate professor of pediatrics and is also a fellow in pediatric clinical genetics at Indira Gandhi Institute of Child Health in Bangalore. He is also the program director for Pediatric Center of Excellence for HIV, IGICH. And for the rare diseases, he is the nodal officer at the Center of Excellence for Rare Diseases at IGICH, Bangalore. He has more than 80 publications and presentations at some of the most eminent platforms. Dr. Sanjeeva will talk about state perspectives and progress made in rare disease management. He'll mostly talk about Karnataka, but let's listen to his presentation. Over to Dr. Sanjeeva.
Thank you, Dr. Mohapatra. At the outset, I would like to start my presentation with a disclaimer. I'm basically a clinician, and my job is to attend patients, and the policies, decisions, and all those are left to the administrator. And I try to help them understand the problem and advise them. But wonder, am I the right person, right choice to address this topic in this platform? I don't know. Let me start my presentation. Can I go to my slides? Yeah. So the story starts in 2014 in our state, when a patient group started knocking the door of government of Karnataka for the treatment. And surprisingly, it was not LSD. It was a primary immunodeficiency patient support group. And it started some interest on executive part. And in the budget of state budget 2014 and 15, a plan was announced, and under that plan, the Center of Excellence at Indira Gandhi came into being. And then nothing materialized. So judicial intervention, which was led by PIL from various groups like LSD and individual patients. So next slide, please. So with this, the state initiative started. There are some of these initiatives are driven by judiciary, but some of them are by the state. So the first and foremost was establishment of Center of Excellence at Indira Gandhi Institute of Child Health, and then some financial support for continued treatment. And importantly, I think probably this is the first state where a cabinet decision committing to share the burden, appropriate burden with the center. Whenever it's worded like that, whenever a central government comes with a policy and they want state to share some of the burden, they are ready. And then another important is the state government has allocated 10 crores for research, seeding money for research under Rajiv Gandhi University of Health Sciences. Now, with this, what do we need to develop a policy? So basically, India is a very genetically diverse country, and pan-Indian data may not really reflect the local prevalence in the context of rare genetic disorder. So that's why we need to have a local prevalent data. And when we say a policy, what does it mean to the patient? For patient, it means that they will have an uninterrupted care of highest quality. To address that, we need to have a good healthcare delivery model. And for the state, they need an affordable, cost-effective treatment options. And for all these things, you need a government support. Can I go to the next slide? Next slide, please. Yeah. So this is the Rare Disease Center of Excellence for Rare Diseases established at Indira Gandhi. It's a daycare unit. Along with that, there is OPD services also. Next slide. And what are the things we have achieved so far? Nearly 4,000 to 5,000 families with rare diseases every year are seen and provided appropriate services. This is in a single center. There are many people who are individually working in our state. And nearly 200 children with various rare genetic disorders, including lysosomal storage disorders, are provided treatment either free of cost or at a subsidized cost. And efforts to develop low-cost, locally produced alternatives are also on. The success story is metabolic diet. It is an effort from our team collaborating with a private company to get a locally manufactured product, which is now available pan-India. Next slide, please. Now with this, what are the challenges to develop a policy or implementable policy? The biggest challenge which is inherent to this whole rare disease is heterogeneous nature. This heterogeneity actually kills to have a good equal or a uniform policy. And another important thing is lack of local data. See, for any policymaker or a financial planner, the biggest nightmare is uncertainty of the future. So every time when you go and talk to the administrator, they always ask us how much you need every year. Unfortunately, we don't have that data. And another another challenge is delayed diagnosis and missed opportunity. This will lead to the missing that critical window of asymptomatic period, during which treatment initiation will result in an optimal outcome. So if you miss that, whatever you do, it will not be an optimal one. Similarly, all said and done, there are only few of these 7,000 or 8,000 rare diseases are treatable. So specific and optimal therapeutic options are not available for the majority of the diseases. And last but not the least is the family commitment. Most of these treatment or care is a lifelong. And there will be initially there will be a lot of enthusiasm with the family to get some sort of relief. Once it sets in and over a period of time, there will be a something called as treatment fatigue, which sets in. And this will have a major impact on the commitment, and then there will be loss to follow up. This will have an impact on the outcome also. They will also imagine a child who is, or a family who is visiting to the hospital every 2 to 4 weeks, loss of daily wages, travel costs, and other things. Next slide, please. So with this in the background, what is the way forward? I think we need to have one generic policy from the central government, which will provide a general guidance and a general approach, because there are 7,000 rare diseases and you have 7,000 different approaches for them. So instead of having individual one, you need to have a generic policy. So technical assistance and operational assistance for a better healthcare delivery. And we need to have something called as quasi-vertical approach, where something is driven by center and the rest of the things been taken care by the state. And most important is robust local prevalence data, which will help us in prioritization. When I say prevalence, I think the equally important is incidence data. Prevalence will give us what we have today, what we need to do today. But the incidence will give us to plan for the future. What is the requirement for in the future and how to plan for the future. And mobilization of resources. Whenever we say resources, it's only money, money, money. It's not just money. There are other resources also equally important. Among them is trained and skilled human resources, infrastructure for testing, treating, and prevention, which is totally, I mean, it's not available at the expectations. Next slide, please. And I think I will spend some time on this slide. Affordable treatment. I think the big onus is on the pharma to bring down the cost. I think it's a high time we need to address this. All these years, we are not talking about this. This is the high time we need to address. Today, with the prevailing cost, I don't think even a single patient family can afford the treatment individually. They are dependent on the state, and we know what the state's this thing now. And I can give you an example. There is a tremendous scope and opportunity to cut the cost. I can give an example. When there was a monopoly for a particular drug, I don't want to name anything here. And when there was a computation, there was a 30% slash in the cost of the drug. That means when there was monopoly, we were paying 30% extra. So there is a definite chance and there is a definite opportunity to cut down the cost so that it will become affordable. And we need to encourage local development of biosimilars or biobetter. Early recognition, I think Madam has already touched upon this. Universal newborn screening, all said and done, 70 years after independence, we don't have a universal newborn screening program till now. There are only few hodgepodge programs we have, but we don't have a universal one. And creating awareness among various stakeholders, developing a common platform. Here, stakeholders doesn't mean public or healthcare personnel. It also includes research and scientists. There are many scientists who are not even aware of such an opportunity exists in the rare disease platform. Next slide, please. I think Madam has touched upon this. The best healthcare delivery model is a pyramidal healthcare delivery model. At the top, you have a center of excellence, and then you have regional care centers and primary care centers with a defined roles and responsibilities, with a robust linkages between these three steps. And currently, what we have is the whole care or whole delivery system is centralized. because the resources what we have is very limited. Probably down the line, when we develop our strengths and when we develop our resources, we can plan for decentralization. That's how most of the healthcare, health policies or health programs in India has been developed in the last many years, many decades. I think we need to follow the same example or same experience. Strengthening of diagnostic and preventive services. I think the preventive services needs to be strengthened in a really big way. Even in big cities like Bangalore, the preventive services is available in only in a handful of, in a very, very scared thing. So we need to develop in a robust way. It needs to reach to the district level and taluk level. That's very important. And phase-wise staggering or scaling up is important. You can't just roll out a pan-India program reaching to the periphery at one stage. Start with a regional centers or a center of excellences. Then with the experience, you can go down to the regional centers and then to the primary care centers. And promoting excellence in translational research is very important. Next slide, please. So I want to conclude that these rare diseases are heterogeneous and too many. So we need to prioritize depending on in our local epidemiological data. And we need to have a robust program for collecting these local prevalence data as well as incidence data. We need to expand and scale up in a phased manner. Pyramidal model for service delivery is important. Research should include technical as well as operational, like your healthcare delivery system. So with this, I would like to conclude my presentation. Thank you very much.
Thank you, Dr. Sanjeeva, for that informative talk. And it's exciting to learn about the Center of Excellence at IGICH. And also, your inputs have been well taken. You talked about prioritization, about cost cutting, about data for action, having affordable and effective treatments, sustainable delivery models. So many aspects you touched upon. One quick question to you. States are so heterogeneous in India. How do they standardize their approaches? Is there a need for a wider dialogue or any other intervention that you would suggest?
Yeah, I mean, that's what I touched upon that. I mean, we can't have a pan-India solution for such a heterogeneous situation. It's not just disease is heterogeneous, the treatment is heterogeneous, and our population also is same. So the diseases which are prevalent in our part may not be the same in the northern India or Western India. So that's why I touched upon a quasi-vertical approach, where a central will provide a general guidelines or a generic policy, and the state with the local data and local prevalence and incidence data can adopt that generic policy to their local need. And depending on that, the center and state can share their resources as well as revenues, and they can build their own policy depending on the local need. You can't have a policy, say for example, a particular disease which is not at all prevalent in South India. If you want to have a policy for that, there is no point in having that. So you need to have the policy which is needed in the particular community. So quasi-vertical approach is the best option, what I personally feel.
Yes, so that circles us back to the prioritization process, where you need to prioritize what exactly you want to do in your particular context. Thank you so much for that presentation, Dr. Sanjeeva. Moving on to our next speaker for the day. It's Mr. KG Ananthakrishnan. So he is the Director General of Organization Producers of India, OPPI, which represents research-based pharmaceutical companies in India. He is well recognized in the pharmaceutical industry for his rich and diverse experience. Mr. Ananthakrishnan continues to mentor healthcare startups and is on the advisory panel of several institutions, along with being a board member of other organizations. Prior to OPPI, Mr. Ananthakrishnan was former Vice President and Managing Director, South Asia Region, MSD India. Previously, he was also associated with Pfizer India, Pharmacia, and Novartis India Limited. He has completed an executive development program from Wharton Business School, USA. He has a master's in marketing management from Jamnalal Bajaj Institute of Management Studies, Mumbai, and a graduation in science from Osmania University, Hyderabad. Welcome, Mr. Ananthakrishnan, and we look forward to listening to your insights regarding industry's contribution and insights for mobilizing partnerships. Over to you, sir. So we have a poll coming in. Right, so we'll, Mr. Ananthakrishnan, yeah, I'll hold you back for a minute. We'll take a quick poll. So 2 questions, please. Can we put up? Yes. So what, according to you, is the main cause of the lack of investment and funding in rare disease space in India? We have 4 options, whether it is a comparatively smaller number of patients, is it lack of awareness, scarcity of prevalence data, or requirement of lifelong therapy? Coming to the next question, what can be the best sustainable funding mechanism for sustained treatment of rare disease patients? Is it center and state contribution, or it is dedication of a portion of health cess? Can I request everyone to choose one option for each question? Right, so let's close the poll. Okay. So it seems that data, generation of indigenous evidence is more important to motivate funding. And it's a joint effort by the state and by the center for sustainable funding mechanisms. So thank you for your responses. Moving on to Mr. Ananthakrishnan, sorry to keep you waiting, sir. Over to you.
Thank you, Dr. Mohapatra, for the generous introduction. You know, distinguished panelists, Dr. Palo, Dr. Madhulika, Ms. Rachel from the US, Mr. Saurav Singh, and Dr. Sanjeeva. I think it's a privilege to be here today to share the industry perspective on how do we address some of these challenges in rare disease. May I request for the next slide, please? I don't want to dwell on this too long, but I think many of the audience here are very familiar with this draft national policy of rare disease, which is there, you know, wherein there are several things that are being talked about: screening and prevention, financial support, alternate funding mechanism, centers of excellence, awareness, and what have you. So the policy is trying to address several aspects of it. If you go to the next slide, there are some of the things which we believe we need to be addressed. You know, while it is a very welcome move that a policy is moving in the right direction, but some of these things need to get really addressed. One of them is, what is the clarity on definition of a rare disease? Early diagnosis of rare disease. How can we try and create adequate and sustainable funding? The sustainable word is extremely important over here. And what is it that needs to be done to increase R&D and awareness of rare disease? Can we learn from the best practices that are there globally? And how can we try and create a multi-stakeholder involvement, you know, so that this problem can be addressed in a very comprehensive manner, which I think Dr. Sanjeev also alluded to it in a very nice manner. And then what are the OPPI companies' contribution towards addressing the challenges of rare disease? Move on to the next slide, please. So if you look at the definition of rare disease, there are varying definitions, and it is our view that there must be one single definition. And one of the good movements that has happened is the definition of the orphan drug. If we can try and make this into one, then it becomes much better, because a harmonized definition of, you know, rare diseases across the, you know, government departments will bring in a consistent policy. Otherwise, we are in for trouble if there are too many definitions for a rare disease. So this is something that we need to address fundamentally. Move on to the next slide, please. If you look at early diagnosis, and this was also spoken by the earlier speakers, access to diagnosis. Sometimes the diagnostics are very, time consuming. How can we try and address these things? Some of the suggestions that we have is government should ensure a center of excellence at the state level, at every single state, so that this opportunity to get screening is done, to get the diagnosis is done, and on top of it, a provision for universal mandatory screening, particularly for the newborn, so that many of these challenges of the newborn developing this disease can be addressed at a much earlier stage. And I think this can really provide a life-saving benefit to the patient if we address both the early diagnosis and mandatory screening in a proper manner and early enough. The next slide, please. And this is something I'm going to spend a little bit more, is on adequate and sustainable funding. See, today the draft policy does not clearly outline what is going to be the central budget allocation for rare diseases. The draft policy does talk about crowdfunding mechanism, but is it sustainable is something we need to really reflect upon. There is inadequate financial assistance for chronic diseases, both in group 1 as well as for group 2 and group 3 diseases. Some of the suggestions that we have is, I think the center must have a budget allocation of at least 500 crores, really clearly set aside for the rare diseases. There must be a provision to increase the fund allocation for rare disease, as and when innovative therapies come to the, into the market. Group 1 diseases, one-time financial assistance cannot be the only one. There must be beyond one-time financial assistance. And it is important for group 2 and 3, disease-specific financial packages are also created so that it really addresses the challenge of the patient. As Dr. Sanjeeva mentioned, sometimes a fatigue develops. How do we try and ensure that these patients get a sustainable funding? Move on to the next slide, please. There should be funding from NHM, which can be earmarked specifically for rare disease. Is there a possibility of having a share of 60% between 60-40 between state and the center? I think if some of these collaborative models are there, I believe that we will be able to address this disease in a much more comprehensive manner. And I'd like to emphasize particularly imperative to create a sustainable funding mechanism. And one thing, is it not the simplest thing to be done? At least waive off the taxes and duties. Today, the patient pays anywhere between 12 to 15% on taxes and duties. This can be clearly waived off because that will help the cost structures to come down, which will be benefiting the patient. Next slide, please. So we need to increase R&D. The challenge today, as everyone has spoken, is low awareness and diagnosis rate. The suggestion is to have a dedicated budget, for research as well as for awareness. It was nice to hear Dr. Sanjeeva saying that there is some provision that is there already in Karnataka state, but I think this should be replicated all across the board. So what should be the, increased diagnostic capabilities, etc.? Let us take one thing. The advantage here we'll have is that suppose there is state level data that is generated and fed into the ICMR registry, I think we will have a much better robust data to monitor both the prevalence as well as the incidence and the natural history, so that the policy decision can be developed in a much better manner. Today, because of lack of data, even the policy space is a little bit vague. This robust registry can help decide what should be the policy for every single rare disease in this country. Move on to the next slide, please. Global developments on rare disease. There are several, researches that are going on, and almost a third of the pipeline from the OPPI are coming from the OPPI member companies. And we would like to mention here, OPPI companies are at the forefront of investigational genetic technology, exploring gene therapy for rare disease, etc. And every effort is being made to ensure that we improve diagnosis, support testing and screening initiative, advocate for and address the needs of the patient, sponsor registry programs, and industry is more than willing to work together. The next slide, please. If you look at learning from the global best practices. There are several of them. We don't have to reinvent the wheel. Rare disease reference network is there, which can be a good one, which we can replicate in India. Subsidized access to medicine, fund research, explores research grants for study of rare disease. Some of them are being done. Can it be done in a very comprehensive and a very well-planned manner is something that we need to really look at. The next slide, please. If you look from a multi-stakeholder partnership is something that we must really work towards. Keeping the rare disease ecosystem in the center, we need state government, we need central government, we need academia, industry, patient group, research establishment to really work together as one unit. Today, I think to some extent it is siloed and hence doesn't get the best impact. If we can invest in multi-stakeholder partnership, I think it is going to give a much better outcome for addressing the challenges of rare disease. The next slide, please. So OPPI companies and rare disease. I think some of you are very clearly aware of this. I mean, OPPI companies are India-centric and patient-driven. We try and bring the global research and therapies to India. We are committed to collaborating with state, central government, and other stakeholders to see what is it that can be done to build capacity, to improve diagnosis, to improve awareness, and the whole length of the continuum can be addressed. To name a few, some of our companies like Sanofi's enzyme, Takeda, Pfizer, and Novo Nordisk are clearly trying to address some of these rare disease areas in a very, very comprehensive manner, including Roche. The next slide, please. So the key takeaways are the following. First and foremost is we need a robust policy and a clarity on definition of rare disease. Early diagnosis of patients and mandatory universal screening. Build a diagnostic capacity and awareness of rare disease at every state level. Adequate and sustainable budget allocation for rare disease. It is not problem at all, because if now is the time, the government is looking at improving the budget allocation from 1% to 2.5%. Part of it must come to rare disease. Robust ICMR registry to monitor prevalence and incidence data. Encourage research into rare disease diagnosis and treatment. Something is being done. Can we do even more about it? And finally, I think it is important to encourage and invest in multi-stakeholder partnership. And I can assure you, my friends here, and also the panelists and the audience, OPPI member companies are more than willing to work together to make a difference to the patients of rare disease. Thank you so much.
Thank you, Mr. Ananthakrishnan. That gives us the industry perspective, which usually as academicians, we do not get a hang of. You have emphasized on the need of having wider whole of society and systems approach. And you have also emphasized on the continuum of care and to learn from global best practices. That definitely gives a voice once so many people start talking together and there is some element of concurrence, then definitely that gives a lot of voice. I have one question for you. Do you see that the different modalities for public-private engagement and convergence have been affected by the COVID-19 pandemic? And if so, how do you see this reshaping?
To some extent, yes, it has impacted because of pandemic, because of several restrictions that were there. But I believe that it was more in the earlier stages of the pandemic. But slowly now, as we are learning to live with this particular problem of COVID, many of these, actions are coming back to, what should I call it as, it's coming back to the forefront in terms of public-private partnerships. I mean, model are getting implemented. But, I would like to really take a few seconds here. If you look today, government is encouraging a lot of public-private partnership models. Right? If you just see the recent, expression of interest which the government has announced on insurance for the missing middle. See, today the Ayushman Bharat covers people from the below the poverty line. The middle income group doesn't get any cover at all in terms of insurance. They pay out of pocket. And that's where the financial burden comes in. Now the government has actually gone one step ahead and has given an expression of interest to insurance companies to come and see, is there a way that we can work out a model of insurance which can address for the challenges of the diseases, particularly the financial challenges, through an insurance model. So government is more than willing now, and that is the reason why Dr. Mahapatra, I'm again and again emphasizing, it should be a multi-stakeholder involvement. It must be the insurance company, it must be the patients group, it must be the government, both at the center and the state level, it must be the industry. If we all come together, collectively put our minds together, we can work a solution for many of these challenges. It is feasible, but we need to come together rather than siloed. So public-private partnership can address some of these challenges in a very comprehensive manner. COVID or no COVID, we need to move in this particular direction.
Thank you so much. I hope that the stakeholders involved take a notice of this. It comes from a very senior person and of course with a lot of wisdom. Thank you so much, sir. For the audience, we'll take a quick poll, 2 questions, and I'd request everyone to choose one option for each. Please attempt these questions. Industry bodies should invest maximum funding in which of the following? So you have 4 options: research for development of therapies, central fund for treatment, public health implementation programs, or direct patient support. Okay, moving on to the next question. Do you think it will be wise to direct central public sector enterprises to place a certain percentage of their CSR funds into the said PM Rare Disease Treatment Fund? Yes or no? Do you think it's wise that there should be commitment of direct central public sector enterprises to contribute directly to the PM Rare Disease Treatment Fund? Yes or no? Okay, so let's close the poll and display the results. Okay, so there is more support to have programmatic interventions, and programs should attract more funding. That's 41% of the people. And of course, there is some emphasis on research on therapies and also direct patient support. So multimodal approach. Now the second one is, yes, there is very strong support to direct contribution to the PM Rare Disease Treatment Fund. So that will be earmarked funding for supporting these kind of patients. Thank you so much for your responses. Let's move on to the next speaker. We have the opportunity of having a representative from a family with a child with a rare disease. So Mr. Saurav Singh is a champion when it comes to the cause of rare diseases, and he's been very active over the past 5 years. So Mr. Saurav and Ms. Richa, they have an 8-year-old son, Master Shaurya, who has mucopolysaccharidosis type 2 Hunter's syndrome, and he has been able to take this as a legal case to the Supreme Court. That was the first case that underwent some kind of legal notice. And subsequently, he has been very active in pursuing all kind of advocacy for rare disease policy with stakeholders at different levels. So that has included the Union Health Minister, the Minister of State, members of Parliament, chief ministers, and other top government and legislative officials. So his efforts in the legal cases have led to treatment funding and support to many patients in the past. So we have this opportunity of listening from Mr. Saurav Singh, who is MBA and has over 15 years of experience in various multinational companies, including telecommunication and banking sector. He has been awarded several times in different platforms. Over to you, Mr. Saurav.
Yeah. Thank you, Dr. Mahapatra. And first of all, hello everyone, and thanks a lot to PPHF and Takeda for organizing such a great platform to discuss about the resilience approach towards rare disease policy in India. Yeah, next slide, please. Here are some efforts to expedite the rare disease policy in India. Next, please. Rare disease. Rare disease is a vast word. Rather, I should say, rare disease is not a disease for the particular person. It's a disease for the whole family. Because the treatment, in some of the cases, treatment is unavailable, or the treatment is available, then it is unaffordable by the family. When a parent get to know that his son is suffering from such rare disease and the treatment is unavailable, they leave the battle in between. They feel that how can I afford this treatment and how my child will survive. So challenges to access the medicine is too high. Parents watch their child slipping into the jaws of death. It's a very painful and difficult situation for a family and friends. Next, please. I am glad to share that the policy is in progress and should not take a backseat due to COVID-19. When there is no policy, parents are hopeless and helpless because of the huge cost involved in treatment. Generally parents when know about the severity of disease, because in these diseases, there are rapid deterioration in the body of the patients. So they are helpless. And no medical insurance coverage are there in India. Rather, they don't support for supportive therapy, supportive treatment. And these patients are advised for several types of therapies like physiotherapies, speech therapy, and etc. And these therapies are also very expensive. Next, please. Out-of-pocket expenditure is so high. Prescribed supportive healthcare therapies are so expensive. The lower middle class and below poverty line families cannot afford this. As a result, these affects people's quality of life, because most of the people cannot afford this therapy from their own pocket. Caregivers need support. Actually, in India, rare disease patients needs full-time attention and full-time care by someone. And in a typical family of India, a mother has to sacrifice for the son, for the child suffering from rare disease. Governments needs to take care and take the responsibility for the patients like other European countries. I know few parents, they are sharing me that the respective governments are taking care of the supportive treatment and therapies. They are having some policies there in their country. So policy for caregivers also should be there in India. Provision of supportive treatment and food supplements free of cost in European countries. They are having the free daycare centers for rare disease children. Next slide, please. Yes, there is a lack of awareness in India. Rather, doctors and patients both lack awareness of rare disease and lysosomal storage disorders. Mostly in rural areas, doctors do not know about the rare disease, lysosomal storage diseases, and the parents go one doctor to other doctor and they roam around the one hospital to other. Difficult to get actual diagnosis. Educational advertisement required for rare disease disorders by the government. Genetic counseling can be the prevention of lysosomal storage disorders. Suppose a couple is having a family history of lysosomal storage disorders, and they approach a doctor and a right time for genetic counseling, these disorders can be prevented. and also for prenatal testing plays major role to prevent from lysosomal storage disorders. Early diagnosis can help to manage disease for some extent. Yes, drug eligibility criteria, healthcare providers must educate the drug eligibility criteria or the formalities to access the medicine in very beginning. Whatever parents, if suppose some parents are working with a government organization, they definitely deserve for the expensive therapies by the government. So the healthcare providers should educate in very beginning. Increased test centers and lower testing costs should be there in India. There are very few testing centers are available. They are mostly in the multinational metropolitan cities. Testing centers are not there in every states. So it should be increased. And the testing costs are so high. A normal general BPL families, even APL families cannot afford the testing costs. These should be reduced so that the normal general people can afford easily and get diagnosed on time. Next slide, please. National Patient Registry. Yes, it is true ICMR has taken the responsibility for National Patient Registry now. It's an important tool to analyze the actual financial burden. It's a single platform or register a patient with a unique ID. Suppose one patient is diagnosed in one hospital, the same patient goes to other hospital and they are registered in different hospitals and the financial budgets looks high. So it is very necessary to work on priority for these things, for National Patient Registry. Procurement of drug. Challenges to procure drug from abroad, especially due to COVID-19, has become a great problem during lockdown. We should work together to resolve these issues. Problem in transportation of medicine in India during lockdown is also one of the major challenges these days. Next slide, please. Next slide, please. Yes, financial burden. The actual financial burden can be analyzed by National Patient Registry. It's a serious matter as minors are involved. Even the different high courts have passed several orders for treatment of rare disease patients because it's a right to life. It's our fundamental right as per the Constitution of India, Article 21. We must work together to achieve this mission to save life on priority. Next slide, please. We must remember today is my child suffering. This can happen to anyone in the future. We must be prepared and not wait for things to be changed on their own. Research on priority. Research on rare disease medicine in India must be started on priority. We have suddenly started research for COVID-19 vaccination. Why can't we also not start research on rare disease medicines parallelly and can set example for rest of the countries? Rare children needs appreciation in society. This is the very, very important thing as far as I am thinking. Rare disease children must get special recognition in the society. They are not appreciated by other children due to their physical disability. They feel ignored and alone. We should develop this new culture. Together we can develop a culture to appreciate the children with special needs. Schools, parents must teach to make at least one friend with special needs or rare disease. And they have to take care and become his mentor so that these children can also feel this earth comfortable to live. Next slide, please. These are the advocacy efforts and supports received. Next, please. Next, please. Next slide, please. Thank you. Thank you so much.
Thank you, Mr. Saurav, for sharing your lived experience and pearls of wisdom from all the advocacy and championing that you have done. You touched upon really several issues. So you talked about awareness, you talked about resource mobilization, need for genetic counseling, drug eligibility, early diagnosis, scaling up of testing centers, and cost and financial burden issues, and also about the national patient registry and drug procurement. I have one question, and this is regarding what role do you envisage for the patient advocacy groups, especially during the pandemic times?
Yeah, the role of a patient advocacy group is very important, because it is the place where the patient feel comfortable to talk about, because general people does not understand the pain of the parents. And the patient advocacy group, there are several kinds of different kinds of patients are already there. They feel their problems, they get the resolution, and they talk about how we can go ahead and how the policy can be implemented, and they can raise their voice for implementing a successful or effective rare disease policy in India for their children. So patient advocacy group is a major, is one of the best place, one of the best platform where the people can talk about.
Yeah, so thank you so much. Perhaps you're trying to emphasize that there is a need to upscale the advocacy efforts that are already on, especially during the COVID time, so that we don't lose focus on the rare diseases. Thank you so much. We have 2 questions from the polls for the audience. Participants, kindly respond to these questions. Should newborn screening for rare diseases be made mandatory by the government of India? Yes or no? Do you want universal newborn screening? The second question is, do you think there has been improvement in the patient care services in the last 5 years for rare diseases? Yes or no? Participants, please choose one of the responses. So there is again very strong support to universal newborn screening. As Dr. Kabra also mentioned, that we have the capacity and we are doing good here. This has to have that kind of outreach and coverage, and we will reach there definitely. Do you think there has been improvement? Yes. So 63%, almost 2/3, believe that there has been an improvement in patient care services over the last 5 years. And of course, this will only be an upward trend. More and more improvement will be visible with time. Thank you so much for those responses. Before we move on to the Q&A session, we are glad to have amongst us the General Manager of Takeda India, Mr. Koki Sato. Takeda is a major global biopharmaceutical company that makes drugs for rare diseases. Mr. Sato comes with over 17 years of diverse experience in the pharma sector, including leading the company in multiple countries across the world. He has taken Takeda India's operations 4 months ago only. It would be interesting to know his views on the rare disease space. Mr. Sato, thanks for being part of this webinar. Over to you, sir.
Thank you, Dr. Mahapatra. First of all, I'd like to congratulate and thanks to PPHF for leading such a great initiative, and of course, all the speakers today for sharing the views on rare diseases. I found it personally very encouraging that all of us here together to support rare disease patients very comprehensively. It is also very important for all of us to appreciate, recognize the fact that the government is showing the commitment toward rare disease by consolidating expert views to address patient needs and issues. It is indeed a very positive step in the direction of ensuring the patient treatment and well-being. Takeda, as global biopharmaceutical leader in rare disease, is strongly committed, continuously supporting, partnering with all relevant stakeholders, keeping the well-being of rare disease patients at the center of everything we do, to ensure larger scale diagnosis, extending patient access to life-saving treatment, and of course, sustainable funding system. Each of us here has a key role to play, and we look forward to holistic and robust national policy that will be path-breaking to the lives of rare disease patients in India. Thank you so much.
Thank you, Mr. Koki, for reiterating Takeda's commitment to keep it patient-centered and improve access to diagnostics and therapeutics. And also your encouragement for coming up with a more vibrant policy for rare diseases with multi-stakeholder engagement. Thank you so much for that message.
Thank you.
I would request all the panelists to please switch on their videos. We now headed for the Q&A session. I see that multiple questions have come up. I would, yeah, Dr. Sanjeeva, is it and Mr. Saurav, is it possible to have your videos on, please? Yeah. Thank you so much. Right, so I see that Ms. Nilovna wants to ask a question. Can we get her on the audio, please? Is it possible to get Ms. Nilovna on the audio? Yes, Ms. Nilovna, we've switched on your audio. You can ask your question. Okay, so while we find her, we have prepared a list of some questions. So, Mr.
Hello, am I audible?
Yes, Ms. Nilovna. Yeah, please go ahead, ask your question.
Thank you so much for all the speakers to have shared such informative inputs and perspectives on their areas around rare diseases. It was really helpful to know. I would really like to understand, in the absence of a policy at the center, how can states really take steps in management of rare diseases? What can be the actions which are the most practical and plausible in the times that we are currently in? Thank you very much.
Okay, thank you. Thank you, Ms. Nilovna, for your question. Dr. Sanjeeva, would you like to respond to that? How can states do better, especially when a policy is not yet available?
Yeah, I mean, I think the answer is slightly difficult. That's because no state government wants to touch this topic, because if they develop some sort of policy on their own, because this has happened with us here, if they really develop some policy on its own, and if it is on contrary or against the policy, whatever is going to come from the central government, then there will be conflict. So at this point of time, I don't think there will any state government will venture into that area, but still they can do some of the components which will help in shaping up the response to this rare disease issue. For example, a state government can have its own prevalence registry where it can collect its own data, and which will help the government or state to develop some sort of response to such diseases. And it can also start building up capacity so that there will be enough skill and personnel available to roll out this, decentralize this whole thing. And they can also, state government can also pitch in creating awareness among public and other people. And it can also pitch into the research, as we have done in our state, with our state health university pitching in some seeding money for research. So local need, it can be picked up for a research question and it can be answered. So some of these things can be addressed, but to have a concrete policy on its own, I don't think state government will be really enthusiastic in having that when the national policy is not yet ready.
Thank you, Dr. Sanjeeva. I hope, Ms. Nilovna, your question is answered to satisfaction. You can have further discussion through us. Before I move on to the next person asking the question, I have two quick questions. Perhaps these are from people who are seeking care advice. The first one, I direct that to Mr. Saurav. So the question is, are there different patient advocacy groups in India, like NORD, which is more international in scope? So are there certain groups that people could reach out to for rare diseases?
I could not get this question. Can you repeat it?
So the question is, are there different patient advocacy groups in India for rare diseases? The way NORD works from the US, no? Are there similar groups that you know of?
Yeah. There are so many patient advocacy groups works in India, and they can definitely get together and raise the voice for rare disease and rare disease policy and the patients, and it will work. Definitely, it will work.
And how does one reach out to them? So a Google search or something? Is it possible to locate these advocacy groups on the internet?
Yeah, definitely. We can search these rare disease patient advocacy groups by typing the name of the patient advocacy group, and we can get the numbers very easily. And there are some email IDs and mobile numbers they can reach out.
Right. Thank you so much. It seems that they're quite reachable. And going to the next question that we have is for Professor Madhulika. So, is genome mapping done for mothers and children in India, and what is the affordability of such genome mapping exercises? Professor Kabra? Your voice is not audible.
Yes, sent a message that the electricity has gone off and she is logging in again.
Okay, right. So let us move on to Mr. Ajay, who wants to ask a question. Can we have him live? Can we have him on the audio, please?
Hi, this is Ajay.
Yeah, please go ahead.
Yeah, I just want to know, how can India partner with the pharma companies to provide access to expensive medicine from abroad?
Yes. So, Mr. Anant Krishnan, would you like to respond to that?
Yeah, see, if you look at several disease areas, the pharma industry does partner with the disease, patient organization, whether it is cancer, whether it is diabetes, and also for rare diseases. It is important that we sit together along with the patient advocacy bodies like what Saurav also shared, to try and see how we can try and help the patient's need. Currently, as Koki Sato also mentioned from Takeda, there are several ways that the industry is trying to collaborate with patient bodies. One is to increase the awareness of the disease. There is a lot of activity going on. The second is, how do we try and facilitate diagnosis of the disease? There again, industry collaborates with the medical bodies, with the patient bodies, to see how that can be facilitated, that is particularly on the diagnosis. The third way where we do is the therapeutics. How can we make the medicines available to the patients, at an affordable price point? That is the other one which many organizations within our member companies works very closely with the patient organizations. The fourth is the policy advocacy part. Here we need to work collaboratively, because if, for example, I go and demand for a tax and duties exemption, it is more perceived in a commercial fashion rather than it trying to bring down the price of the drug for the patient. So if we work together as medical organization, as patient bodies, I think we will be in a position to try and address many of these challenges that are there in the whole continuum of the disease, right from research to the outcome. If you look at it, there is a lot of opportunity for collaboration. And that's the reason why I emphasized a lot on that multi-stakeholder partnership, to address some of these disease challenges.
Thank you. Thank you so much, Mr. Ananthakrishnan. You touched upon again multiple aspects of it. We have Dr. Kabra back. So we had a question for you, Professor Kabra, and it's regarding genome mapping for mothers and children.
Okay.
So is it available in India and what costs?
Yeah, so when you say genome mapping, what we actually mean is that we are talking of sequencing of the genome. So we usually, for diagnostic purposes, in some situations, we do, as of now, exome sequencing. And it is not a routine. So we do select cases where we are strongly suspecting a Mendelian disorder, and we have not been able to make a specific diagnosis based on the first line tests and the clinical examination, and we have a family history pedigree which is suggestive. Then in that situation, the affected child and the parents can undergo, which we call as exome sequencing, and based on that, some diagnosis can be arrived at in a certain proportion of cases. So it is not routinely done for all cases. We have to select cases and then can be done. And yes, it is available in India.
Okay. Thank you, Dr. Kabra, for the response. So we're getting more and more questions, and I must ensure that dear participants, the entire recording of this webinar will be available, and the questions pertaining to care, capacity building of care providers, their awareness and all, have already been touched upon in the previous presentations, especially in Dr. Kabra's presentation, so you can refer back. We can take one or two more questions, but in the meantime, I'd request the panelists to quickly summarize one line, summarizing the entire gist of their presentations before we wrap up for the day. Let's go to Professor Kabra first, then we'll flow in the sequence.
Okay, thank you, Dr. Mahapatra. So all I need to say is that we are moving in the right direction. In the last so many years, India has really done well, and capacity building in the area of education, diagnostics, even some part of treatment and research, and the community education has gone in. But we do have a long way to go, and in all aspects, we really need strengthening. But then we should go with a optimistic note that we are doing well, and putting in certain efforts in particular areas and getting support from all the stakeholders, as we just listened to many presentations today. So everybody has to come together, and then I'm sure we will be able to go in a right direction, and we will be able to take care of patients with rare diseases in our country. Thank you.
Thank you, Professor Kabra. The question comes back again. So you talked about this genome sequencing. So is it affordable?
Yes. Okay, so as of now, the cost of, if we talk, there are many types of sequencing. So if we are talking of whole exome sequencing, the cost varies, and most of these are available as of now in the private sectors, not within the hospitals usually. And in the institutions, it is usually being done on research basis. The cost varies, but then it is approximately 25,000 to 27,000 per sample if you are undergoing whole exome sequencing. So there are some options available for free testing under research and under some programs, but then that might take a little longer time if you are sort of wanting an immediate diagnosis.
Thank you so much, Professor Kabra. Let's go to Dr. Sanjeeva. So, sir, summary points, take-home messages from your presentation, please.
Yeah, I mean, rare diseases being so heterogeneous, it's one pill, one cure approach will not help in this situation. So we need to have a robust local data and depending on that, you can prioritize our local things. And we need to develop some sort of a healthcare delivery model, which should make the accessibility easier for the patients. And I mean, COVID has started a lot of things. For example, telemedicine, how it's been pitched into the management of these patients. And we need a lot of, I mean, the focus should be more on research to develop local, affordable care, affordable alternatives for these some of these things. And there are many diseases where we don't have an answer, so we need to develop some sort of an answers for them also. And the whole program, you can't start on day one reaching to each and every person at the last mile. So it has to be in a phased manner and staggered scaling up. So that should be the answer. Start with central thing and then slowly decentralize. We should remember that whenever we talk about decentralization, it always comes at the cost of quality. So the quality will suffer when you decentralize without a plan. So you need to have a good plan so that the quality is not compromised. Because for these diseases, you need an utmost quality and a lot of collaboration with a team. Not a single person can handle this. So we need to develop such sort of an capacity and decentralize. I think that should be our way forward. Thank you.
Thank you, Dr. Sanjeeva. There is one question, quick question to you. If you were to assess practically the capacity that we have in the country, are there one or two disease conditions or organizations who can take this up as a starting point? Do you see there is capacity to identify one or two conditions that could be taken up for public health organization advocacy?
I mean, you want me to name a few diseases?
No, it's up to you.
No, I mean, I don't want to be that, because I mean that will not be an appropriate in this form. I mean, there are many. I think Madam will agree with me, and she has been on board. Yes. She knows what are our priorities and other things. Yes. I mean, I think government will have that overall holistic look on that, and we should not be taking any particular name here.
So that's a crux from Dr. Sanjeeva. There is a need to build consensus on what kind of epidemiology needs to be prioritized, and it has to be multi-stakeholder decision, not just one or two constituencies deciding on it. Let's move on to Mr. Ananthakrishnan. Sir, summaries from your presentation. Sir, you're muted. Please unmute yourself.
I look at it this way, that we are going through a crisis of COVID, but let's take that crisis as an opportunity. I don't think we have seen the type of focus health has received now in the last 4 months, any time in the last 3 to 4 decades at least, or even more. Health has now come under priority and is having tremendous amount of focus by the government. I think this must be taken as an opportunity to see how do we try and shape the new policy that is, in a draft form. Can we work together? Because from the policy will flow everything, whether it is at the center or at the state level. So it's that. The second, as many of our panel also mentioned, is establish an incidence. That's the second one. The third is most important. Again, how do we try and ensure there is adequate and sustainable funding? This has to be government driven. And can we also develop certain models to ensure that we have adequate and sustainable funding mechanism? Encourage research. I second what Dr. Sanjeeva mentioned. We need to do a lot of local research on rare diseases and also address them in a very comprehensive manner. And then finally, I reiterate again and again, any disease, and more so rare disease, we must invest in multi-stakeholder partnership. It cannot be addressed by any one constituent by themselves. You have to come together, we have to put our heads together, we have to work together to ensure that we find a good optimal solution for rare disease. Thank you very much.
Thank you, Mr. Ananthakrishnan. Mr. Saurav, to you.
Yes. As far as I'm thinking, we should start working on awareness part, first of all, because most of the people are unaware about the disease and the severity of the diseases and how they will get the treatment and how they will get the funding. So we should work on awareness on priority. And government should also work for medical insurance, how
I think we just lost connection with Mr. Saurav. We have 5 more minutes to go. Dr. Paulo,
the medical insurance company can cover supportive treatment. And yeah, so it should be prioritized. Means from that we can analyze the financial budget, and we should also start the supportive therapies to the patients suffering with these diseases. And free genetic testing should be there in the country so that everybody can easily afford these genetic testings. And the caregivers should also get some support from the government according to their capabilities categories. So these are my points.
Thank you so much, Mr. Saurav, for summarizing it. Dr. Paulo, 1 or 2 quick closing remarks from your side before.
Thank you, Dr. Mahapatra. I think working together is the kind of message. We need to work as in a platform, maybe some kind of a coalition of the organizations, institutions, patient groups, policymakers, and the pharma companies and the whole network, scientists and everything. That's one probably is the one way to prioritize the agenda, and policy is important. The policy should come quickly. We hope that will be released soon. And one important focus area is sustainable funding mechanism. That's what the everything, kind of starting from awareness to access to treatment and capacity and research, kind of need to be prioritized. So resource is very important. I think that is something probably we need to work together. So if we can work on these couple of ideas, probably we can have a better position to address the challenges. Thank you.
Thank you, Dr. Paulo. That really sums up the whole story. So this has been an exciting 2-hour journey, and we have touched upon many updated aspects regarding rare diseases. During the pandemic, when it is really tough to have sustained focus on rare diseases and keep on upscaling the advocacy efforts, these kind of discussions, these kind of plenaries should actually pave the path for more concerted efforts. I really take pleasure on behalf of PPHF, GRID, and Takeda to thank the experts who contributed their time and experience to today's discussions, and to the participants for being very active with the questions and with the polls. I thank Professor Kabra, Dr. Sanjeeva, Mr. Ananthakrishnan, Mr. Saurav Singh, and Ms. Rachel from Nord US for their messages and for summarizing their essence of understanding. So thank you so much. It has been a good journey, and we hope that we'll have more discussions around the plight of rare diseases in our country and worldwide. Thank you.
Thank you.
Thank you so much.